All right, it is 3 o'clock, so I am gonna get started introducing today's webinar. I do see that there are quite a few more people who have registered who have not yet logged on, but I do want to welcome everyone who's here so far for participating in today's webinar series. My name is Marie Eagle. I am a project coordinator with the ARC of Michigan. We are very excited to continue offering this monthly webinar series on all topics related to person-centered planning. Today, we'll be hearing from representatives from our federal compliance section. The federal compliance section is located in the Quality Management and Planning Division and oversees the behavioral health, home and community-based services, also known as HCBS, approved by the Centers of Medicaid and Medicare Services for children and adults with serious mental illness, serious emotional disturbance, intellectual and developmental disabilities, including autism spectrum disorder. Today, we will be hearing a high-level overview of the current waivers for youth. So that would be the Children's Waiver Program, the ABA, and the SED Waiver programs. And I am going to stop sharing this screen. We will first have Angelo Powell, and Angelo will be here to talk about our Children's Waiver Program. Yeah. Okay.
All right, good afternoon. So Marie, you want to proceed to the next slide. I think your introductory included the next slide. So why don't we go to where we'll start? And actually, I will present on both the SCD waiver and the CWP. One more slide, please. So our goal is to provide a basic knowledge of the waivers, and we're going to do that by providing a high-level overview that basically accomplishes 3 things. One is to provide information around how to access the waivers. 2, how the eligibility criteria for each waiver, which will help you to identify potential waiver candidates. And then 3, what to expect in terms of behavioral health services covered under the prospective waivers. So the slide on the screen now is the prepaid inpatient health plans, commonly known as the PIHP, and you're looking at the PIHP map. Our contract for operations with the waiver was historically directly with the CMHSPs, but as of 10/1/19, as of 10/1/19 waiver renewal, we moved our contract from the CMHSP to the PIHP. So each of the 10 PIHP regions are responsible for the administration of the waivers at the local level. Next slide, please. So we're going to start out with the SCD waiver. In the SCD waiver, we serve 2 priority populations. The first population is the traditional population, and the traditional population is pretty much the catch-all. So the traditional is any child living in the community with a parent or legal guardian, with or without Medicaid, who meet SCD Waiver Eligibility Criteria. And this would also include private and international adoptions. And the reason why we distinguish private and international adoption is because of our second priority population. Our second priority population is the DHHS project. And the DHHS project includes children who have open foster care cases through the Michigan Department of Health and Human Services, or the children who are adopted out of the Michigan child welfare system. So the only difference with the second bullet under the DHHS project is, all children adopted out of the Michigan child welfare system will fall under our DHHS project. Any other form of adoption, and the child also meets SCD waiver eligibility criteria, they're eligible. They would just fall under our traditional population. Next slide. Okay. So the eligibility criteria for the SCD waiver is basically, there's three main eligibility criteria. And the one eligibility criteria is that a child must have a primary SCD qualifying diagnosis. Most of the children that we work with in the CMH world would have a SCD qualifying diagnosis. Children on the waiver must receive at least one SCD waiver service other than Wraparound per month in order to retain eligibility. The children also must meet either state psychiatric hospital admission criteria or risk of state psychiatric hospitalization without the provision of waiver services. Then also a child must demonstrate functional limitations, and functional limitation for the SCD waiver is measured by a tool, three tools actually. It's the functional assessment tools are CAFAS, PECFAS, and DECA. The tools are used based on age range. So depending on the child's range, depending on that child's age will determine which one of the functional assessment tools would be utilized. Wraparound is a mandatory service for the waiver. We'll talk more about Wraparound later, but any child and every child enrolled in the SCD waiver must also participate in the Wraparound planning process. Once eligibility for the SCD waiver is established, the eligibility is good for 1 year. And then annually, we reassess eligibility through what's termed a recertification process. The SCD waiver is attended for 1 year with the possibility of a second year. And then under circumstances in which a second year is completed and the child still meets eligibility criteria for the SCD waiver and still in need of SCD waiver services, then there is an option for the third year. However, the department will undertake a higher scrutiny of that second recertification for the third year. All children enrolled in the SCD waiver must be 18, under the age of 18 at time of enrollment. But if the child after post age 18 continues to meet all non-age related eligibility criteria and also are in need of waiver services, then the child can remain on the waiver up until their 21st birthday. Next slide, please. So this slide covers our waiver services. So children enrolled in the waiver have access to Medicaid state plan services, as well as enhanced and additional waiver services. So those services are listed here on this slide. They're community living supports, family home care training, family support and training, therapeutic activities, which include recreation, music, and art therapy, respite care, child therapeutic foster care, therapeutic overnight camp, wraparound, which we all stated was a mandatory service that's included here on the slide, home care training, non-family choice voucher, and then a new service, overnight health and safety support. A couple of notes on the services. So I mentioned that a few of the services are enhanced. The enhanced services are basically CLS and respite. Any child with Medicaid under the state plan has access for community living support and respite. However, children enrolled in the waiver have access to quite a significant amount of respite and CLS. And that is by design because the population of children that we serve and the parents and guardians who are responsible for these children. It was determined in planning of the waiver that CLS and respite would be two services if provided at in an adequate amount would provide the support necessary to help serve the children and maintain them in the community. So because of that, the CLS and respite are considered enhanced services. There's some additional services, meaning that the services are exclusive to waiver children and not children enrolled in the waiver and not available to children under state plan services. Is therapeutic overnight camp. Not to be confused with camp. There are some CMHSPs have offered camp, and especially through wraparound historically outside of the waiver, but within the waiver, children have access to 3 camp sessions per year. A session is consecutive days is what constitute a session. Doesn't matter if it's 3 days or 14 days or 20 days, doesn't matter. Just consecutive days is what constitute a session, and children have access to 3 sessions per year with a maximum fee of $1,400 per session. And that has proven to be a very helpful service for families and children and families. Then also our therapeutic foster care is also another service that's only exclusive to children enrolled in the waiver. This is a service in which when all other services have proved, even including with waiver service, have proven to not be quite enough to maintain a child in the community without high risk of out of community placement, then this service provides even more intensive therapeutic intervention within the community with a host family known as the therapeutic foster family. So we can talk more about the services, or you can find more information about the particular services in the Medicaid provider manual. And then if you have any questions, of course, you can ask those questions and we'll clarify. Let's see, is there another note on the services? I think I covered most of the services notes. All right, next slide. So this slide talks about wraparound. And as I mentioned, wraparound is a mandatory service for the SCD waiver. And, you know, I have a long history with wraparound. So if some of you folks are out there listening and have a reaction to wraparound being mandatory, no worries. Wraparound is always voluntary, but when a child meets that eligibility threshold for for the waiver, we have never had a family who would not welcome supportive services, and particularly a service as supportive as wraparound. Wraparound is more of a process than a service. And what the wraparound process provides is a highly individualized planning process performed by specialized trained wraparound facilitators. So the wraparound facilitator has the heavy load, I like to say, with the SCD waiver, as they are the folks who actually, once eligibility is determined, they actually meet with the family. Their responsibilities include orientating the family to the waiver, as well as orientating them to the wraparound process, confirming that once they orientate the family to the waiver, that the family would like to continue and proceed with waiver services. And once that piece is completed, then the wraparound facilitator is responsible for supporting the family with identifying the wraparound team, identifying unmet needs, developing the plan, and coordinating and collaborating with all the system partners out there in a way in which to help the services and the service delivery to not be so overwhelming for families, and to help the families to navigate the different systems and system partners involved. So wraparound is the key to the SCD waiver. Next slide, please. So the SCD waiver application process. The front door for the SCD waiver is the CMHSP. The PIHP, we contract with the PIHP, but the PIHP delegates the assessment of the SCD waiver, of SCD waiver eligibility, to the CMHSPs. So if a family or a referral source would like to refer a child to the SCD waiver, then they should contact the local CMHSP and specifically request the SCD waiver. By doing so, the CMHSP is contractually obligated to assess SCD waiver eligibility at no cost to the family. And I think I covered the wraparound piece, the second bullet. Let's see here. Yep, the second bullet, it identifies what I didn't mention. I had talked about the wraparound facilitator being responsible for orientating the family and to assuring that the family would like to proceed with the wraparound process, the SCD waiver. And the actual form in which the family signs indicating their agreement with proceeding with the waiver is called the Family Choice Assurance Form. So there's a copy of that form on this slide. The facilitator secures the signature. The CMHSP SCD waiver lead is responsible for submitting the SCD waiver application and the waiver support application online to the department. This is a good time to mention that every CMHSP has SCD waiver leads embedded, and the SCD waiver leads should serve as the local expert, at least the agency expert, for the SCD waiver locally. There are SCD waiver leads at the CMHSP, PIHP, and the local DHHS. So those are your frontline folks. And then if there's other information that's needed or technical assistance that your local waiver leads are unable to answer, then the waiver folks in federal compliance at the state, then we are also available to assist. Next slide, please. Okay, this sign simply says This slide simply indicates who can legally assign the Family Choice Assurance Form. And this is more of a technical slide. You guys don't have to be aware of this information. The CMHSP and the wraparound facilitators, they are aware of this information. So we'll just proceed. You can take a look at it for your reference if you like, but this is actually not that important to you guys. Okay. So the desired outcome for the Child Welfare Project, early on we identified, shortly after the implementation of the SCD waiver, it was identified that there is a population of child welfare children who could also benefit from waiver services, and the outcomes that were identified with utilizing the SCD waiver for serving children, child welfare children, are listed here. So we would like to maximize fiscal efficiencies across the service system, of course, we all have a common goal of children living in the least restrictive family setting in the community. And not only do we want to help children to achieve progress, but we also have a shared goal with children achieving permanency with a family in the community. And then if all of that is, if we're successful with all of those goals, then children have improved functioning across all life domains. Next slide. So all children who are residing either in a licensed foster home or with a relative caregiver and enrolled in the SCD waiver, the family will receive, or they're eligible for, a $50 per day determination or difficulty of care rate. The DLC rate is not specific to the SCD waiver. Actually, the waiver during its design, since children served in the waiver are our most intensive population of children served in the community, it was determined that we would have a set rate, which is a higher rate than having to go through the traditional DLC rate determination process. So that's why with the SCD waiver, if a child is enrolled in the waiver and they are residing in a licensed foster home or a relative caregiver, then the $50 a day DLC is pretty much automatic. There is a process. There are specific tasks that must be performed by the foster parents who care for children receiving SCD Waiver services, and those specific tasks are listed on the DHS 1254, which is the form that the foster parents actually review and sign in lieu of receiving, not in lieu of, excuse me, in order to receive the $50 a day DLC rate. And the DHS worker is responsible for facilitating the payment request and the approval of the DLC. Okay, next slide. There was a common question around whether or not more than one child in a home can be enrolled in the SCD waiver. And the short answer is yes. This slide details some particular circumstances in which we as the department would scrutinize whenever we have more than one sibling or child in a home that are referred to the SCD waiver. When it's biological siblings, of course, with Wraparound, the best practice would be to serve the identified child and then also, take a look at the needs of all the family members, including siblings, and try to address those needs in the Wraparound planning process with a single client. In some cases, children's needs are just so severe that a separate SCD waiver is necessary. But whenever there is more than one SCD waiver child in a home, then the family has to agree and understand that you would have, in addition to that second SCD waiver, you also are agreeing to having separate Wraparound team meetings that meet all of Wraparound requirements for the individual child. So you can't, have two children enrolled in a waiver and then cover both children's needs under a single Wraparound. The services are totally separate, but you do have the benefit of the SCD waiver for individual children. We don't, at the department, we don't scrutinize the number of children enrolled in the waiver, that we trust the CMHSP and PIHP to make that determination. However, if there's more than 2 children, then the department will actually take a look at the situation and really maybe even consult with the PIHP and CMHSP to get a better understanding of why more than 2 children in a single home would need waiver enrollment. And then we would have a really detailed and in-depth conversation around what that would look like in terms of time commitment and family or parent and legal guardian's ability to, handle more than 2 waivers at a time. And this more so comes into play in foster homes. And historically, it hasn't been the foster parents who have set themselves up for this situation. More times than not, it has been because you have a very good foster family who works very good with children. And of course, we have a system that's taxed. And so well-meaning workers will place children in foster homes more. And what we found historically is that beyond 2 children, it's just not doable for a set of 2 parents. But anyway, enough on that slide. I think you guys get the gist. I probably talked too much about this one. So we're going to move on to the Children's Waiver Program. Much like the much like the SCD Waiver, the CWP is authorized under Section C of the Social Security Act. It allows the state to waive parental income and assets and make a child eligible for Medicaid as a family of 1. And then the CWP, much like the SCD Waiver, provides additional services specific to and limited to the waiver population. Eligibility criteria for the CWP. The CWP serves children up to age 18. Also, the child has to be eligible for Medicaid as a family of 1. And they must reside in the community with a parent or a relative who has been named a legal guardian. And also, the child must have a developmental disability as defined by Michigan state law and meet institutional level of care. And with the CWP, that would be ICF and IDD. Yeah, we can skip past this slide as well. That's just another slide emphasizing the institutional level of care. So children, the referral process for the CWP is access is similar to the SCD waiver. At the front door is the CMHSP. And what we encourage the CMHSPs to do is to assess the eligibility for the SCD waiver. And if the child is found eligible and they do not have active Medicaid at the time of the referral or assessment for the CWP, then the CMHSP is responsible for performing a pre-screen. If a child is Medicaid eligible at the time of referral for the CWP, then the CMHSP is responsible for providing all medically necessary supports and services. So we actually encourage the CMHSP to not perform a pre-screen on children with active Medicaid. So a couple of considerations is for proceeding to the pre-screen portion of the referral process is, does the child have a developmental disability? Does the child meet criteria for ICF, IDD level of care or risk of, and also that they're in need of active treatment? You might want to consider what service needs the family have identified. And then also, can services be provided through the CMHSP and or other resources, including a commercial insurance benefit? Next slide. This particular slide lists the pre-screen factors. And again, this slide is more geared towards the CMHSP, who's responsible for performing the pre-screen, but there are 10 factors listed. Actually, there are 9 listed here. They're not even 9. Yeah, there's 9 factors listed, and those are the different areas of consideration for the CMHSP to perform the pre-screen. The pre-screen determines the eligibility is already determined. That's why the CMHSP proceeds to the pre-screen. The pre-screen results in what's called a pre-screen score. That pre-screen score is what determines on our weighing list where that child's falls in terms of priority or number on the weighing list. Historically, the CWP functions at full capacity at all times, hence the need for a weighing list. And the pre-screen score determines where that child spot is on the weighing list. When that child reaches the top spot or the top number of spots that are of invitation issued monthly, that's when the child will receive an invitation to actually complete the application for the CWP and start CWP services. Next slide. So both waivers, both the SCD waiver and the CWP, whenever a family specifically requests the waivers, then the CMHSP is contractually obligated to assess eligibility. But in addition to that, if a child is found not eligible for the waiver, then the CMHSP must provide the family with notice of denial and also notice of Medicaid fair hearing rights. This throws some folks off out there because typically only Medicaid beneficiaries have access to Medicaid fair hearing rights, but because the waivers serve as a pathway to Medicaid, CMS has mandated that anyone denied the waivers also have access to Medicaid fair hearing. Next slide. The pre-screen, once again, the pre-screen is performed when eligibility for the CWP has been determined, but yet because we operate typically at full capacity, the child goes on the waiting list. And we can't determine how long a child may be on the waiting list because the waiting list is actually a living list, meaning that a child's priority slot will change when a new child is added to that list if that new child's score is higher than the child who's already currently on the waiting list. So in order to keep the list and the priority up to date for children on the waiting list, we have 2 updates. The first update is basically a brief update that is performed 6 months after the initial pre-screen. And then a full pre-screen is due annually. And those updates will continue until a child is either no longer on the waiting list because they are either no longer qualified or the family no longer wishes to pursue CWP, or the child is issued an invitation and enrolled in the CWP. Next slide, please. And again, this slide simply illustrates what we talked about already. So once the slot becomes available and the child's score is high enough to where they are eligible to receive an invitation, and invitations are issued monthly, then the child will, the family will receive notice of the offer, the slot offer, and that task is delegated to the case manager through the CMHSP. So the case manager will contact the family, inform them that the child has been offered a slot. They will confirm that the child is still in need of services, that the child is still a current resident in the community, that they're still Medicaid eligible, and that the family still desires the waiver. And if all of those bases are covered, then the case manager proceeds with the process to finalize the enrollment of the child in the CWP. So the CWP approval process, once the application for the CWP is advanced to the department through our web-based application, the WSA, the clinical review team reviews the waivers. We determine that we confirm that eligibility is met. So the CMHSP does the initial eligibility determination, but the final eligibility determination occurs at the state level. Then there's a few steps that occur where we approve. Then we generate all the necessary approval documentation. We forward them to our Medical Service Administration, who sends an approval packet to the family. The approval packet includes a letter, which is the formal approval letter that goes to the parents. It also includes the actual Medicaid application and detailed instructions on how to complete and submit the Medicaid application, as well as supporting documents necessary to process the Medicaid application for the waiver child as a family of one. The family submits the Medicaid application. Shortly afterwards, they will receive a Medicaid card in the mail, and then the child will have full scope and coverage Medicaid, which covers both behavioral health and physical health services. Prescription, just as I stated, is full scope and coverage Medicaid. Next slide, please. Services available to children for the CWP. Again, children enrolled in the CWP have access to all Medicaid state plan services, as well as additional services included under the waiver. And all services identified and needed are included in the individual plan of service. Next slide. So this slide illustrates the services, the services that are available under the CWP, in addition to the state plan services as CLS and respite, which are both enhanced services, very similar to the SCD Waiver, enhanced transportation, environmental accessibility and adaptation, fencing, family training, non-family training, fiscal intermediary, specialized medical equipment and supplies, and then again, the newest service, which is overnight health and safety support. Yeah. Transition planning is very critical for both waivers. With the CWP, when a child turns 18 and that child is still in need of services, oftentimes the child will transition from the CWP to the Habilitative Support Waiver, more commonly known as the HSW or HAB waiver, and services should continue seamlessly. The second bullet point just simply illustrates that the CWP does not have to wait for needed services, because if a child is eligible for because the child is eligible for state plan and which is our former B3 services provided by the PHP, even if there's no HSW slot immediately available. So that's kind of our catch-all, and which assures that services should occur and be delivered regardless to a particular circumstance or slot availability. Choice voucher is basically provides parents of minors a method to control and direct how their child's IPOS is implemented and who provides certain services. Choice voucher is available under the waiver, so it must be offered to children enrolled in the CWP, but it's totally voluntary. So the families can choose to utilize choice voucher, or if they're more comfortable with the traditional service delivery, then they can continue with that route as well. It's totally up to the family. That concludes the overview for the SCD waiver and the CWP. I know that there will probably be a need to answer questions, so we'll collect those questions later, and we'll be happy to answer all of your questions. So I'm going to turn it over to Morgan Vandenberg at this time.
Thank you, Angelo, and I hope everyone can hear me. We have a small group today. But I guess it's a beautiful day, so I don't blame you. Just quickly, we're going to give a high-level overview of the ABA or the autism benefit, as well as some updates related to COVID and sort of the terminations of our disaster relief waivers. So first off, if you look in our Medicaid provider manual, you may question why does it say behavioral health treatment? Well, behavioral health treatment is the umbrella in which ABA services are covered. So right now, ABA is the only treatment modality covered under behavioral health treatment, and that's section 18 of our chapter. So for the purposes of Michigan Medicaid, those acronyms are pretty much equal. So you can interchange them, but we typically now know it as ABA. Next slide. So for ABA, when we rolled out this benefit in 2013, it was under a different authority, but we carved out all initial comprehensive diagnostic evaluations for all individuals with Medicaid. So if a child has Medicaid and they're going to their Medicaid health plan or physician for their well child visits, the health plans and those other contracted entities with Medicaid would perform those screenings and those tools in accordance to the ages and stages in development, and they would refer anyone that they thought may need further evaluation, and including ruling out ASD or autism spectrum disorder. So all of that is carved out to the PIHP system. So we do cover a comprehensive diagnostic evaluation, which is defined here as a neurodevelopmental review of cognitive, behavioral, emotional, adaptive, and social functioning, and should include validated evaluation tools. Again, this comes after a medical or physical evaluation ruling out some of those sensory or hearing issues, and so now they need a ASD qualified practitioner to conduct a more comprehensive diagnostic evaluation to determine if this child has autism or other sort of conditions that may require additional services or treatment recommendations. So based on that evaluation, the practitioner as it relates to the ABA benefit should be determining that initial diagnosis, recommending general ASD treatment interventions. So it may be common to see them recommend OT, speech, sort of other services and therapies, counseling for the family, as well as they'll refer them on for a behavioral assessment to look at ABA services, which is an evidence-based practice and what we cover. So we have a very sort of carved out benefit as well as our provider network. So our evaluations have to be performed by what we call a qualified licensed practitioner. We typically call them QLPs. They have to work within their scope of practice, and they have to be qualified and experienced in diagnosing ASD. So this goes beyond just sort of the general licensure. They also have to have experience in diagnosing. So some of those examples in our provider network for QLPs are physicians, psychologists, advanced practice registered nurse, PAs, which again, in the CMH system, I don't think we have too many in network. Typically what we see is the next one, clinical social workers. Again, it can't just be any clinical social worker. They also have to have training experience or expertise in ASD and or behavioral health. And then as always, our PHPs and CMHSPs have always been able to incorporate any outside evaluations as they take everything into consideration when completing eligibility determinations. So they may be getting additional sort of reports from early on, or an IEP or an IFSP from the school districts. So they're able to take all of those evaluations into consideration when they're evaluating against the scope of enroll within the benefit, which is the diagnosis, recommending treatment interventions, and referring on for further evaluation. Next slide. So many of you who I see on today are my PHPs and CMH ASD coordinators. So they may be tracking on this, others may not. But there has been in the last 2 fiscal years budget boilerplate under our section 960 Autism Services that outlines some legislative requirements and standards, as well as they can require. This year or last year, they required a work group and sort of a legislative report from the department on administrative expenses related to the ABA benefit. So you may have seen, or you may not have, but you can Google it afterwards. Section 960 in FY22 basically aligns the diagnostic evaluations and the reevaluations with the public health code, or the insurance reform that passed in 2013, which then would align Medicaid with those standards that wouldn't require a diagnostic evaluation to be done more frequently than 3 years unless medically necessary. So in December, we did do a policy bulletin, sort of adjusting some of those things that were legislatively input in previous boilerplate. So it wasn't in our state plan, but now it was in our state law. So we've been weaving those into the policy. And so you'll see in the final bulletin that should be posted this week. And again, those final bulletins are sort of your Medicaid provider manual until the next chance the provider manual gets updated and actually gets incorporated into the other Medicaid provider manual you're used to using. So this will require no more than every 3 years and more frequently if needed. And again, the practitioners that we identified earlier are the ones that can recommend an earlier sort of frequency. So again, those QLPs should be basing that on the child's age or developmental level, the presence of comorbid disorders or complex medical conditions. So there'll be additional guidance provided in training through our partners at AOM and Wayne State University ongoing next year to assist with fleshing this out a little bit more as we continue to update the policy and disseminate this information to become effective later. So it's not effective today, but what is effective today is MSA Bulletin 2058. So we already are covered and have dropped or suspended or modified our prior authorization, our reevaluation requirements via that policy, and CMS has approved those disaster relief waivers that allow us to do that. So right now, the removal of that annual reevaluation ADOS is already in play and sort of already being implemented across the state due to the impact of COVID. Next slide. So we talked about that initial comprehensive diagnostic evaluation. There's also another category of beneficiary that already have a confirmed diagnosis of ASD. So they're able to utilize, again, and leverage those evaluations with that confirmed diagnosis. Or if they're following that initial diagnosis, the next step would be to make medical necessity authorization and recommendation of the ABA, BHT, again, by that qualified licensed practitioner. They're the ones that will be authorizing initially and reauthorizing. So our state plan, so this is in the federal law, is that ABA services are authorized for a time period not to exceed 365 days. So that is a federal law, and our QLPs are the ones working within their scope of practice that would then reauthorize the next year and recommend ABA ongoing. Next slide. And again, you're not re-diagnosing, you're reauthorizing the service. So there's a lot of sort of confusion and some blending of diagnosis versus, eligibility and diagnosis and prior authorization. So again, those ongoing supports and training will be occurring in the future and are earmarked again in the boilerplate under Section 960. But under ABA, there's a variety of evidence-based interventions that are covered, including parent training or parent-mediated interventions. And again, if you track on this, the public health code, there was a recent bill that opened that up and added it to the insurance reform. So it's now a state mandated and a covered intervention under the public health code. So it will, when if approved and passes both houses, it would become an intervention covered under the insurance benefit. Medicaid, we already had that identified as a covered intervention, but the public health didn't. So again, we're aligning so that there's reciprocity and sort of parity between coverage. Next slide. And again, after they have been enrolled into the ABA benefit, you have your assessment, but the service level, the setting, this is always one. Is it home? Is it center? Is it community? Those are all sort of addressed during that planning process and outlined in the IPOS. Actual hours needed versus recommended are again sort of teased out during that person-centered planning process, and the interventions required that the ABA provider will input in the behavioral plan of care, which is an extension of the IPOS. There's a common myth that there's some sort of minimum or maximum to stay enrolled, which again is a myth. But again, our PHPs are phenomenal. If you go to our website, you can find their contact information and continue to to work with them on any of your questions or concerns within the benefit. And then our behavioral plan of care is just a living document, again, adjusted over time. Some of the children we work with really excel at or master a lot of their goals and objectives quickly. So you may have to adjust the plan of service or amend it or add different services. So it's, again, just adjusted over time based on the data, the response to interventions. And so the treating provider, the ABA provider, should be working really closely with the case managers. And we have a lot of wonderful case managers that are sort of dedicated to just the ABA benefit, and they've been phenomenal to work with. So just, again, love the case managers, especially in Region 2. I think they do a really great job of, connecting and being that link between provider and that clinical world and the families. But again, the planning team and guardians will be reviewing the IPOS at regular intervals or as needed. And per contract, again, PHBs are the that authorize the level of service prior to delivery of ABA. So that was sort of a very quick and overview. We can go to the next slide. But I think the thing I want everyone today to take away is to continue to use the 2058 COVID response bulletin as your Medicaid provider manual. It should be overlaid the original Medicaid provider manual as what is the requirements and standards, and what are those flexibilities or changes in provider qualifications, for example, or prior authorization or telehealth. This should be what you should be using, should be at your desktop and continue to reference, because it's in addition and overlays the other chapters and sections. Additionally, I just want to kind of plug the telemedicine proposed policy. It was open for public comment, but if COVID has taught us anything, is that telemedicine needed to expand. For ABA, we already offered 2 of our services via telepractice, but with this telemedicine expansion across Medicaid and across behavioral health and the MSA, we'll be able to continue that and even expand it further to increase access and to connect access to specialty providers. So just, again, link them in. I know the slides will be sent out, but another plug of a great resource to reference and continue to reference, especially the telemedicine policy as the final bulletin comes out. Next slide. So again, policy and guidance updates are changing, very quickly. So continue to go to michigan.gov/BHDDA, BHDDA, and on our landing page, you'll see this link, and it'll take you to updated policies that may be significant to the work that you do or oversee, or one of the programs or services that you administer. Different guidance and different resources are constantly being developed as things change, as requirements change. So just another sort of plug to continue to check that out for up-to-date information. And since this is a children's kind of focused webinar, school guidance and sort of collaboration and coordination with public schools, there's a document on that link as well. Next slide. And then with telehealth expansion via the COVID flexibilities that we've been approved for, I just wanted to let everyone know that these resources are available on our website if you want to look up what's currently approved in our encounter code chart throughout the public health emergency. So what services are allowed, who can do them, as well as how to report them. And then when I talked about that proposed policy of telemedicine, there is another link for the telemedicine database that'll be post-COVID. So you can see which services have been earmarked to be part of that expansion for Medicaid, even when these other disaster relief waivers expire. And then I also wanted to give you a resource of who to contact at Buddha for any of this telemedicine expansion, COVID-related policy, and service reporting. We have a mailbox dedicated to that. Next slide. So I know many of you probably see that the U.S. Department of Health and Human Services are the ones that make that emergency declaration and are the ones that are continuing to sort of re-auth or sort of continue to establish that each authority extension occurs. And so they're the ones that really decide the duration of the emergency and declare it, in which we can continue those disaster relief waiver authorities, and those flexibilities continue. So the secretary can authorize them in 90-day sort of intervals. So you'll see that since January, there's been multiple sort of redeclarations or renewals. And the latest one happened in April, which gives the public health emergency period go to July 21st of 2021. And I expect probably in July, there'll be another 30-day or 90-day extension per the history and sort of the cadence and sort of how Corona has impacted this country. So for up-to-date information on those declarations, so you can have a better understanding of when those flexibilities are pending or may terminate, and to plan ahead, I just linked those federal websites here, as well as some other really good mental and behavioral health resources for all providers within Medicaid. Next slide. So this is just a really quick glance at all the different authorities that we have concurrently running that are allowing us to do everything that's outlined in Bulletin 20-58. So right now, to cover all the authorities that we use within Medicaid and all the programs that we cover, we have three different sort of COVID-related authorities that we had to sort of braid together in order to standardize and allow the flexibilities to ensure access to services and to alleviate some of the admin requirements in order to focus and address or sort of address and respond to the pandemic. So we have a Medicaid 1135, and its effective date was March 10th, but the termination date is at the end of the PHE. So if we were going off today's declaration, that would be July 21. And the 1135 covers a lot of sort of providers out of network, a lot of the provider enrollment. It touches a little bit of eligibility, modifications to person-centered planning, telehealth expansion, and that covers our state plan services. And then we have our Appendix K, which will cover our 1915C waivers. So Angela went over our CWP and SED, and we also touched on the HAB. All three of these waivers, we have an Appendix K that became effective on March 10th as well. This one has a little bit of a different termination date, so it will expire no later than 6 months after the expiration of that national PHE. And again, check that website, around July, or if you're on a listserv, you may get alerts that it's been renewed. And then for behavioral health, we have a third waiver granting us K-like flexibilities for our state plan services, including ABA, which I touched on today. And this was effective March 1 retroactively. This was the last one CMS approved for us, but it basically mimics the K for all of our state plan benefit services. So whether it's through the I benefit in the 1115 or ABA or any of those other family supports and sort of base level state plan services we provide. And this termination is a different date. So it expires no later than 60 days after that PHE. So I just want to, again, for planning purposes and so that you're tracking on it and understand all of the various authorities and which sort of programs and services they align to, put together this table. So again, we have to take action, all states do, to terminate those temporary authorities. So as we're planning for, you know, getting back to normal upon the conclusion of the PHE, again, we will notify the PIHPs and CMHs via bulletins in accordance to that MSA 2058 bulletin of which ones will extend and which ones will be sort of fired or sunset. And we have sort of, through our guidance from CMS and resources they've provided, kind of an understanding of the timeline and what our state's obligations are to sunset those dates and to sort of restart those regulatory standards and requirements that we had prior to COVID and to sort of transition back to those. But given that, I think, again, CMS was very clear with states that if it was going to negatively impact a beneficiary, again, that terminations of benefits or if they were granted enrollment for a longer duration, that any like adverse or reduction of benefits, we would still have to utilize the Medicaid process of notification, and they would have the same fair hearing rights. We can't, although the requirements sort of are game back on, we still have to follow all of our Medicaid requirements, not just some of them. It's not as simple as, you know, turning on a light and turning it off, that there's a lot of things to consider, and that if we are going to impact their coverage or reduce their benefits or change their eligibility type, that they would still get the same sort of Medicaid covered rights. All right. So again, each temporary authority adopted by states to respond to the PHE is scheduled to automatically sunset upon termination or another specified date. So those dates vary by authority, and continue to look at that table in order to gauge and sort of keep your, you know, on your radar, those that are upcoming for planning. So again, our team at Federal Compliance, each one of our program leads have been phenomenal, I think, in working with our PIHPs and CMHs and sort of preparing everyone to have an understanding of those expectations and how they would impact the programs that you either administer or are part of operating. So once the PHE ends, we have to take the appropriate steps in redetermining eligibility and terminate coverage as appropriate, or if they've remained enrolled, say they extended their level of care evaluation, it continued post the due date, we would start looking and taking those appropriate steps to address that, to make sure that we start addressing that backlog of anything that was allowed under those COVID flexibilities. So here's just another general sort of outline of the state's obligations and how we will have to start kind of re-engaging and implementing those regulations again. so that we can eventually, hopefully, get back to normal operations. And then that's really it. The last slide is really our contact information. I know we're over time. Today is my probably last webinar. So I gave Belinda Hawks as my supervisor as the contact for federal compliance, and then also Angela Powell, who presented today, and Monica Erickson, who works on the SED, but is also going to be our program specialist overseeing our 1915I. I think, did you want to start, Monica? I don't remember. we're training right now. So she'll be that point person. So I wanted to give you those three contacts. And again, Marie and ARC will, if any questions you have, you can put in the chat or send, and we'll get those directly from her to respond. So I think that will conclude us today. Is there anything else, Marie, housekeeping wise, before we end today's webinar?
No, I do think that's it. We did have a couple of questions that were asked in the chat that we don't have a chance to get to, but I copied those and we'll get you a response.
Wonderful. Thank you so much. And everyone have a wonderful day. It's beautiful out. So tell your boss the state that I get out early.
Yes, thank you, Morgan and Angelo, for the information. And as we said earlier, we'll be sending out a link to the recording as well as a PDF of today's presentation. It comes out tomorrow. So thank you, everybody, for participating.
Thank you.
All right.